I guess the question is yes and yes. I mean, I think it's absolutely practice changing. And again, just as a reminder, I mean, this actually was a 3-arm study. The standard of care, of course, was FOLFOX, and there were 2 experimental arms. One added nivolumab to FOLFOX, and there was a 3rd arm of ipilimumab and nivolumab. And I think, as Dr. Moeller, the discussant or the presenter mentioned, they're reserving presentation of the IPI-NIVO data to a later point, but that arm actually was closed early, either because of increased toxicity or futility, we don't know, but those results are also pending. But certainly comparing the Nivo FOLFOX versus FOLFOX arm, the nivolumab plus FOLFOX arm did better, and it did better in its co-primary endpoints of progression-free survival and overall survival, which is certainly impressive. But it also did better technically in the 3 groups that were looked at. So the primary group that they looked at were in patients where the tumor PD-L1 CPS score was 5 or more, and it met its primary endpoint in those patients. They then went and looked at patients with a lower degree of positivity, CPS 1 or more, and they also benefited. And finally, when they looked at the intention to treat population, which includes some proportion of patients where the tumor is just not PD-L1 positive at all, they also seem to benefit. Having said that, the hazard ratio seemed to go up the lower down you went in terms of the PD-L1 score, meaning that patients were getting less and less benefit. So I think the clear winner and the clear choice is that if I have a patient in clinic today with a tumor PD-L1 scores, CPS 5 or more, I would immediately try to get them nivolumab on a compassionate use basis. I think what remains a little bit unanswered is that if the score is between 1 to 4 or 0, whether those patients benefit as well. Because it may be that, the majority of the benefit, when you look, for example, at the intention to treat population, which is everyone, most of the benefit maybe was driven by the CPS, 5 or more patients. I think it will be important as an additional subset analysis to take a look specifically at outcomes in the CPS 0 patients, in the CPS 1 to 4 patients, to see whether we can, see any hints of activity. Again, the study may well be underpowered for those patients, but I think it would be important as a clinician, to see the activity in those groups. And certainly from a regulatory perspective, I'm sure the FDA and other regulatory authorities will certainly want to scrutinize activity in all of the groups. But the clear winner is the CPS 5 or more. One could also justify adding nivolumab to FOLFOX, for the other groups as well, because ultimately in the intention to treat population, ultimately everyone seemed to benefit. The other reassuring thing is, as one would expect, there were not increased or additive or synergistic toxicities from adding nivolumab to FOLFOX. You certainly have the toxicities of FOLFOX plus, the known immune-related toxicities of nivolumab, but nothing was worse or unexpected.